The classification as I have developed is as follows. Behavioral expression that will arise from impairment in regulation of sensorium are disorganized behaviors. Behaviors that arise from impairment in information processing circuits are the misidentification behaviors. Behaviors which emanate from impairment in motivational circuits are apathy behaviors, goal-directed behaviors, motor behaviors, and importuning behaviors. Behaviors which arise from impairment of emotional regulatory circuits are vocal behaviors, emotional behaviors, and fretful, trepidated behaviors. And finally, the behaviors which arise because of impairment of self-regulatory circuits are oppositional behaviors, physically responsive behaviors, and sexual behaviors. So right off the bat, if you collect information that falls under a behavioral category, it immediately gives you a clue to which part of the brain it's coming from. So that's the first understanding of the behavioral expression. So this is the scale, the behavioral scale, which I developed, has been validated, has been published, peer-reviewed, and it outlines all of these behavioral categories, starting with disorganized behaviors, misidentification behaviors, goal-directed behaviors, vocal behaviors, emotional behaviors, fretful, trepidated behaviors, importuning behaviors, apathy behaviors, oppositional behaviors, physically responsive behaviors, sexual behaviors, and motor behaviors. Now, one of the things you'll find, the scale's been laid out differently than how I showed you, and a part of that is because over the years it's allowed me to use the scale also when it comes to using medications. How behaviors move along the scale it gives me direction on which medications to use. So it's a bit of a guide for most people, and we're developing those treatment algorithms as we move along by utilizing these scales. But the important thing is you have to understand where the behaviors are. Let's move on to trying to understand the first behavioral category we talked about, which is behaviors which are based in impairment in regulation of sensorium. And we've talked about this. These are the disorganized behaviors. So what are some of the symptoms under the disorganized behaviors? Appearing vacant and lost in facial expressions. The sort of the expression, the lights are on, no one's home, kind of a disposition. And we disorganized thinking, a very, very complicated term, disorganized thinking. Unintelligible, garbled speech, rapid shifts or incongruency in emotional disposition, playing with things, stuff, smearing and all that stuff, and mental and or physical lethargy or a general functional decline. Now, remember, what happens when there is impairment of sensorium? When there's impairment of sensorium, there is impaired reaction time. We talked about that. There is impaired processing speed, and there is impaired chunk of information that goes into the brain to be processed. Those are the three things that go wrong when your sensorium is off, whether it's alertness or attention or both. Obviously, if it's alertness, the attention becomes a part of it, and most times it's the two together. So why is that important? The reason why it's important is there are certain theories in neuroscience that say if your alertness and your attention is affected and the information that goes into the brain circuits is impaired, it significantly impacts on task performance. And it can go either way. It can slow down or it can speed up. But both ways, you're going to see an impact on task performance, and it's not going to be healthy. It's going to be because of a disease state. You guys in the trenches, I don't know how many times I hear there's something different. You guys saying there's something different about Mrs. Smith today. You guys know them well. You know what they are, how they act, how they respond, regardless of the MMSE, because that's not something we carry in our mind all the time when we deal with people. We just know how we interact with these people. And as we interact with these people, we know what their quote-unquote baseline is. And then for you to come and say to me there's something different is the most important thing I can hear from you guys, is this is not baseline. Or Ms. Smith is more confused. Now we all work in a world where everybody is confused. And sometimes it becomes belaboring. She was really confused. Well, yeah, I know, that's why she's here. Or he's here. But is it different from usual? And that is worth $1 million. If you guys can give me, or people around you, your registered staff who can then pass it on, just the fact that you're saying that there's something different or the person is more confused is the key to recognizing right away sensorium has changed. And that itself can save you a lot of headaches. I mean, those were again the items in the scale. So here's the trick with this. First of all, remember, you're not supposed to collect these if they are the baseline for the person. You're only supposed to mark on this category if it is a change from baseline. Because everybody with MMSE of 9 has disorganized thinking or speech or whatever. No point collecting that. That's their baseline. So the idea here is to determine changes from baseline. And what's easier to detect changes from baseline and which lead to comments of the types you've talked about, something's different about Mrs. Smith today, or she's more confused today, is they appear more vacant or blank, i.e. they're not responding to you. You come and say, Mrs. Smith, good morning, how are you? And every day, whatever she would say, smile or whatever, even throw a pillow at you. She didn't do it today. And you kind of stop and say, okay, well, what's the matter? Why didn't you throw that pillow at me today? And if it happens 2 days in a row, that's very significant because 7 days before she did that every day. So that is a change. It's as subtle as that. Again, mental, physical lethargy sort of, slow down, decline in function, and we talk about this all the time. What's different about this person in their function? Till yesterday, they could feed themselves. Today, they can't. Till yesterday, they had no trouble with swallow, and today they're pocketing. A few days ago, they were, bowel incontinent, but not fecal incontinent, but now they're both. So that's a change in baseline function. Things that you guys deal with every single day. Nobody is more aware of those things than you guys are, because you are in the trenches And that is what you deal with is function. All I'm looking for from you is identify for me even the slightest change from baseline. Because as soon as that happens, it immediately tells me that there is something happening to sensorium. So these ones are difficult ones, and I'm not going to talk about them because we can spend the whole day with this stuff, particularly disorganized thinking, because that's a term even I don't understand what it means. What is the purpose of this measure? Purpose of the measure of disorganized behaviors, that there is a change in confusion from baseline. Please don't share the baseline, because we know why they're here. But what you need to share with me is change from baseline. And in other words, what this behavioral category, or the purpose of this behavioral category, is to make us aware, you and I, as healthcare professionals, is there are superimposed muddled states in this individual. And that's what I'm looking for, is can you detect with your clinical acumen, your clinical involvement, if there is another level of confusion. Not the confusion they came to me with or that you've known all along. So what is the meaning of the behavior? If you see this, it basically is the patient is telling you, you look after me, I'm different, I cannot tell you, but I need for you to understand that something in my body physiology has changed. That's the meaning of this category. This is what the individual with dementia is telling you. You can take it, you can ignore it, or you can recognize it, most importantly, and then take it forward. Because that is what is being portrayed by the patient to you. They're basically saying, I can't tell you what's wrong, I can give you a hint. My body physiology has changed. So, when does a body physiology change? So that takes us to the approach to care. If you detect this, what is the approach to care? There is either dysregulated physiology or there is illness. If it's dysregulated physiology, then it could be something as simple as fecal loading. How many times we deal with that upstairs? Somebody's more lethargic, they're not waking up. Turns out they haven't been evacuating their bowels. Or bladder retention. Or changes in hearing. Because, as we all know, if you have cognitive impairment and your hearing diminishes, then your cognitive impairment exponentially worsens. They break their glasses. They can't see as the same way. So all the information going in is now blur. If the information going in is blur, you can't expect accurate information coming out. So, dental issues, circadian rhythm changes. Now we all know these people go through phases and changes in their sleep-wake regulation no matter what we try. If they are on a cycle, they'll have 3 days of sleep, and the 4th day they must stay awake all night, and the next day what happens? They're out. And their sensorium is changed, their function is changed, and then they might do things which will fit this. So then if that's not the case, then obviously infective workup. And this is the only time bladder infections, in my opinion, are important and relevant. Rita's smiling. Because bladder infections don't create behaviors. unless it's delirium. They don't worsen behaviors, but they worsen function. They worsen sensorium. And when that happens, then you get into this category. Same with metabolic workup. If somebody has a very high sugar, they kind of look like deer in the headlights, the non-ketotic sugar states, or if their electrolytes are off. But even more important in all of this, the one part that is responsible, in my experience, 99.9%, are the medications. And it's not because something was changed yesterday. It could be 2 months ago. Everything takes its course. So one of the most important things you can do by recognizing this, because when this is happening, you call some of our experts in, they'll give more risperidone. But this is the time where you need to clean things out. Because if you recognize something as simple as this, you can do your individual the biggest favor, is take away medications. And it could be any. It could be pain medications, from narcotics to pregabalin. It could be cardiac medications, calcium channel blockers. It could be psychotropic medications. So it isn't that just psychotropic medications can do it. A lot of medications can do it. And if you recognize this category, if you understand what is happening, then what you've just done is you've diminished the medication load of your individual by at least 60 to 80%. And invariably when I go in, I can recognize when it started, but there was more, because something's different. So the key here is your patient is telling you, my physiology has changed, and you pick it up, and you go back and take a look at the chart, and you recognize what's happening, and start cutting and burning and slashing, and you'll see them come awake. And then you'll deal with the other behavioral expressions that you have to deal with.